all you folks basically are on mute, and it'd be nice to see some faces, but it is what it is. However, I brought my buddy with me tonight. So Taz is joining us tonight, if you can see him. He's not even a year old yet, and super, super sweet poodle with a man bun, compliments of my 6-year-old granddaughter. So let's do this. So bear with me. So sometimes I can't chew gum and walk at the same time. I want to make sure that my screen is shared. And in sharing the screen, do you all have a picture of my pediatric cardiac arrest file? What you should see is our new branding with the teddy bear and the star quilt. Are you seeing that?
We've got it.
All right, fantastic, fantastic. Michaela, do you want to go ahead and run that poll real quick, and let's see how folks do? So Michaela's going to run a poll, and she's asking you to answer the questions. She's got it timed. Thank you, Michaela.
Okay.
Okay.
Go to the next question. Do you want all the questions or just one?
Let's hang on to this one here real quick, if I can. So this is one of the interesting ones that I find all of the time. One of the things that we hear is I don't run pediatric calls. Pediatric calls, one of the things that we need to keep in mind is pediatrics are from birth to the age of 18. So those where our pediatrics fall into. And in all honesty, if you go back and kind of track, we're between 7,000 to 8,000 calls a year for EMS agencies. I think we've seen a few more calls for pediatrics this year, but 7,000 to 8,000 is typically what we have in any given year. And we can go to the next one if you have it.
Okay, it should be up.
Okay, so with being a pediatric champion, so a pediatric champion or a pediatric emergency care champion with EMS agencies, just to kind of give you a heads up, South Dakota EMS for Children, that's part of our performance measures. There is a, our whole goal is to have a pediatric champion within every EMS service. Currently, I have over 80 EMS services who, out of the 120 services that we have, that are a pediatric champion. And with that, we're developing a program. It's going to be called PEC Perks. And with that, there'll be perks of education, resources, training, and a number of other things that are going to kind of go with it, but you'll be the first to know about it prior to. So just kind of give you an idea that it's kind of worth it to have a pediatric champion within your group. Ask if you don't know who that pediatric champion is, you might ask whoever your director, president, or whatever title that they're going by. So fantastic. Oh, look at that. So just to give you folks an idea, over the last couple of years, this has kind of changed. 25% has been what we've had as our baseline for the number of children that we might see across the United States. We have 22% is where it is for 2019, and that's CDC information and kids count information. With that, so you can kind of figure within your community, 22% of your population is pediatrics. And where are most of our pediatrics when we are looking at where they're located during the day? They're either in school or they're in daycares or somewhere on that order. It's really important to keep that in mind. The other thing that I want to bring forward to you is I am sure within your community that you have a child who is has children or youth with special health care needs. And we look at that number as well. So children with special health care needs and those kids who are medically fragile also fall into that category. We look at that 19% across the United States. I've done a little bit of research in the state of South Dakota. It says 10%. However, we're losing a little bit of our population. There's a huge loophole in that. And where that loophole actually runs, it runs in the fact that all of that is tracked through the school system. So it's tracked through the school system. So you may have a child who has cerebral palsy, or you may have a child who has a trach, and that child does not have any special learning needs. So that's the loophole that they fall into. I'm guessing, or I would venture to say that our children with special health care needs more than likely probably falls into more than probably 20 to 25% is probably where we are with our children with special health care needs. And that's important for us to know because we're going to launch a project that goes with that as well. All right. Oh, how many of you are proficient using the Brazo tape? Okay. That's where we're kind of seeing some changes, folks. I see about 60% of you are kind of saying no, you're kind of hesitant about it a little bit. We're in the world of the pandemic. We've lost a lot of our muscle memory, so we haven't had the opportunity to do a lot of our skills and things. That's where I'm going to challenge you basically to jump back in there when you are within your EMS services and you're having your meetings and however you're doing it, social distancing, whatever the case may be, that you're actually putting your hands on this equipment and you are proficient in it. And we'll kind of get into that a little bit later. But as we kind of visit and talk a little bit more, our muscle memory has decreased quite a bit, especially with pediatrics. So we want to kind of keep an eye on where we're doing or what we're doing. And even if you even know where your Brazo tape is. Alrighty. So this gets us into a little bit more about what we're going to talk about tonight. So we have out of hospital cardiac arrest, and this is for pediatrics or related directly to pediatrics. What do you think the survival rate is for a child who has a pediatric crisis at home or motor vehicle crash, whatever the case may be, and we end up with a cardiac arrest? What do you think the survival rate for those kids are? Okay, so I'm gonna jump ahead just a little bit with that. With the number that we're looking at about 6% survival rate once they get home or discharged from the hospital. When we take a look at that a little bit closer, only about 3% of those, the infants survive from a cardiac arrest, and 9% of the children and or teens survive. So with that, there we go. But thanks for taking the poll, folks. It's kind of good to get an idea of where you folks are. Hopefully, once we do this presentation, you'll have a better idea of some of the things that we're looking at. Ready to roll. All right. So if you kind of take a look, Michaela, I thank you so much for the invitation today. It sounds like we're just getting a good kickoff. How many folks do we have that are joining us tonight? I think I saw over 30. Anyway, welcome, folks. This is a really a pleasure to have you folks here. I want to bring to you pediatrics. Pediatrics are their halo events. And what a halo event is it's high acuity, low occurrence. So again, when we go back and we talk about pediatric calls, our number of pediatric calls that we typically see are only about 10%. And that may be in your community, maybe you only have one call through the entire year, or maybe you get a barrage of calls and then you have 2 or 3 calls. So that's one of those things that we want to pay attention to is so critical for us to be prepared for those pediatric calls. And I kind of get where you guys are coming from. So I'll tell you a little bit about myself. Obviously, you met Taz, i.e. Taz, the Tasmanian Devil. My name's Carola. I've been the program director for South Dakota EMS for Children for several years now. I've been here since oh my gosh, I think 2014, 2015, I came on board with Dave Bohr, and then Dave has since retired. I'm a 30-year paramedic veteran. I have worked rural, metropolitan, and I've worked flight. And there's some things that you don't know about me. One of the things that you don't know about me and kind of why I do what I do. Two of my first calls, so I'm from Nebraska. Don't hold it against me. This is really hard because I can't see faces. But please don't hold it against me. I am from rural Nebraska. And what facilitated me to move forward and do more for my community was the fact that one of my first calls was a little gal. Her name was Darcy. And Darcy was headed to school early in the morning, 17 years old, head on a collision at the top of a hill, probably during this time of year where we get some of that fog that kind of lays heavy. And with that, we were a BLS unit, and we did CPR code 3 all the way to Yankton. So I lived 6 miles out of town. That takes a little bit of time to get into town, jump in the ambulance, and then you go 6 to 7 miles out of town. You extricate your patient, and then once you extricate your patient, then you head up to Yankton, and for 45 minutes we did CPR, and that was pretty well all we could do. There was no Lucas device. Looking back, blunt trauma. But I have those same emotions that you folks feel when we look at our small communities and we are either related or we know someone very, very well. And then we take it on to Jeff, who was a 14-year-old boy, Jeff was in a strangulation. So Jeff was out doing chores, and he was in the feeder wagon. So it's the silage feeder wagon, one of the older ones where it's the chain driven one, and it comes up and it goes out the very, very top. So Jeff had a big sweatshirt on, and it was a big hoodie on. And what happened was his strings for his hood got caught in the chain. His sister was actually running the tractor, got caught in the chain, and it basically strangled him down. Fortunately enough for that one, we were having a meeting in the ambulance hall. And as we were having the meeting in the ambulance hall, we flew out there. His dad actually cut him out, I believe. And then with that, we rushed him up to the hospital again, Yankton, South Dakota. And Jeff did survive that. Our community was absolutely amazing. Even though you live in a town of 800, all of our intersections were cleared. Firefighters were amazing. And Jeff so the time I spent out in North Carolina, Jeff has since graduated from UNC, University of North Carolina. If you're a Tar Heel fan, you're either a Tar Heel fan or you're a Duke fan, and he is a physician, and it's amazing. So that's some of the things you have. And yes, I have pediatric calls. I have those pediatric calls that'll bring tears to my eyes. I may or may not share those. We all have them. So just kind of give you kind of an idea of where we're coming from. So I'm going to take you on to our pediatric cardiac arrest, and we'll move forward with that. I hope you folks like our new branding and our new logo. We're pretty proud of it. And let me see how I'm going to move this forward here, Michaela. So there we go. So here's one of the things that I need you to do. How many of you say, I hate pediatric calls? Or you get that, I'll call it pediophobia, and pediophobia is real. Pediophobia is the fear of kids. And this is something we need to kind of take a look at, and we need to have a good concept of what's going on. At the age of 5, you have already made up your mind what you can and cannot do. It's kind of a weird little thought process, but you need to change your thinking, and you need to drop your limitations. And when you get to a pediatric call, you need to realize that all things are possible. And these things are possible by you accepting accountability and knowing that when that pediatric call comes in, that you're ready. And our whole goal with EMS for Children, AHEC, SIM South Dakota, is to bring these cases forward for you to make you more comfortable. But I can only make you so comfortable without, I I can't hold your hand. So the accountability has to come from you. When we look at how proficient you are with the Brazil tape, that Brazil tape should be something that you become very, very proficient with, that you are able to lay it out. You know where all the information is. You dig the equipment out, you put your hands on it, and the more you do it, folks, the more you're going to be prepared. Kids tug at your heartstrings. They tug at your heartstrings probably more so than any of the calls that we actually have. So just kind of keep that in mind. If you have negative thinking, I hate pediatric calls. I don't want to go on a pediatric call. Pediatric calls are the horrible calls. Negative thought processes bring negative results. So how do we change that is what we want to look at. The other thing we're going to take a look at is we're going to talk about some objectives tonight. Excuse me. Our objectives are going to be, we're going to look at the pediatric assessment triangle. I'm going to give you a little bit of a different curve on the assessment triangle. It might make more sense. When we look at the assessment triangle, we're like, yeah. But what I want you to do is pay attention to what the one that I have here, because it's going to clue you in on a lot of things. We'll take a look at the primary causes of pediatric cardiac arrest. Then we're going to talk about how do you treat the rhythms. We'll talk about tachycardia and bradycardia. Michaela, am I talking too fast? Because I do tend to talk fast, folks.
I think you're doing good.
Okay. So somebody either send a text or something and let Michaela know that I need to slow down. We're also going to talk about the pediatric chain of survival, and prevention is one of those that our office is focused on. And then how do we manage pediatric cardiac arrest? So that would be your asystole, PEA, VFib, VTAC. When do we use the AED? How do we use the Lucas device? Can we use the Lucas device on pediatrics? So just to give you an idea of where we're going to go from there. So here's the pediatric assessment triangle. I love this triangle, and the reason I love this triangle so much is the pediatric assessment triangle is basically an across the room assessment, and you've heard it time and time again. But what do you folks notice different about this particular triangle? So it's gray. It doesn't have all the pretty colors to it. But if you look at the appearance, the breathing, and the circulation, what's the word behind that? It's triage. So when we are triaging, so we have green, yellow, and red. Obviously, red is going to be, we need to get moving, we need to do things fast. So when we look at the pediatric assessment triangle, our first thing that we're going to look at is an appearance. And you can walk in the room. You can listen to your dispatch, what dispatch is kind of telling you. With that, if this kid is tracking you with their eyes, it's got to be age specific. And I'm hopeful that all of you have had interaction either with children, grandchildren, nieces and nephews, other family members. Kind of pay attention to what these kids do when they're brand new babies to the time they're 14 years old. You know, when we look at a 14-year-old and they're rolling their eyes at you, you know that things are probably pretty good. And then we look at the breathing triage. So when we look at breathing, are they normal or do they have central cyanosis? Central cyanosis is that they're have cyanotic lips, and their bodies can be off as far as pallid and mottled. We look at our breathing obstructed disorders like the stridor, the croup, things on that order. So keeping that in mind. And then you look at the circulation to the skin. Your circulation, so appearance basically is kind of where we start, but we want to tie all of these into, because it really ties into circulation. And when it ties into circulation, that's where we got to keep our things in mind. So this basically triage, or this pediatric assessment triangle, it helps you triage in less than 30 seconds. You folks do it every day when you go on to a call. It gives you the idea, is a kid sick or not sick? If you have an appearance of a child who is either unresponsive, they're limp, they may be inconsolable. Inconsolable would be that maybe they're hypoxic or they're so hypovolemic that their circulation is trying to keep up with that. That child is a sick kid, and it's time to go and time to roll. You don't need any equipment. All you're going to do is you're going to use your eyes, and you're going to use your auditory clues with that. There's three components again. That's your appearance, your work of breathing, your circulation. Your circulation problems affect each one of these components in identifiable patterns. So when you look at the lower left-hand corner, if there are no issues basically coming up and no red flags on the appearance, they're stable. If we look at a child who is show in red in that unresponsive, lymph, apathetic, or any of those things, then they have central nervous system and metabolic issues going on. We need to pay attention to what's going on with that. And then of course we look at shock on the very lower hand corner. Either it could be circulatory or it will be your appearance and circulatory basically kind of going together for the signs and symptoms of shock. Testing them. Then we look at the other portion of it on respiratory distress. So we know if we have someone in respiratory distress, that's in your lower right-hand corner. Respiratory failure, that's going to be your breathing and your appearance. They're going to kind of come together. So if you think about respiratory distress as that kid who maybe be in that tripod position, they're breathing, you've got audible wheezes, and you can see that they're tiring. That would be your respiratory failure. And then cardiopulmonary failure is when you have all three of those things kind of going on at the same time. So let me see if I can get back over here. So somebody give me the quote of the day for this. I absolutely love this picture. Either type it in or something, type it in and let Michaela know. What kind of answers do you have, Michaela?
I am not getting anything right now. Let's see if someone will. What's normal? Is that so? This is where
just put a fun quotation to this picture.
This is supposed to go where?
I love it. I look at this one, my quotation kind of comes for it is rectal thermometer. What?
There's one that says, I think it's room temperature.
Yeah, it's a really cute, it's a really, really cute little picture, I think. I just absolutely fell in love with it. So when we want to talk about a couple of different things, we look at our little quote of the day. This child, obviously, if she's messing around a little bit the way she is, her appearance, it's a fun little appearance. She's probably doing very, very well. So when we get into work of breathing, let me see if this is going to work. I'm not sure if it's going to work. Tell me what your thought process is on this. Let's see if we can get this to work. Things are a little slow. I apologize, folks. Here we go. What's your thoughts on this little guy? Sick or not sick? How are you going to treat him? And how fast are you going to move? See his little tummy going up and down, the little seesaw breathing that he's got going on. He's a super sick little guy. Work of breathing that describes your child's respiratory status. If the circulation to the vital organs are decreased, the child's respiratory rate will increase as well. So that's something to kind of keep in mind. There's a thing called effortless tachypnea. It's common in, it's a common sign in hemodynamic instability. So hemodynamic instability, that's when we could look at blood loss. We could look at fluid loss. So maybe hypovolemia. Hypovolemia is the #1 cause of kids who have either circulatory problems or they go into respiratory arrest. Fluids are our biggest issue that we have with kids. Increased work of breathing, retractions with him. I don't know that we actually saw any retractions with him. We did see the seesaw breathing. We hear the grunting, the stridor, the nasal flaring, all of those things. Those are red flags, folks, and you want to be ready to move quickly. One for what you're figuring out you're going to do for your treatment. The other one is they may or may not be present with their circulatory. So you can have a kid who has stridor and they're very stridorous, but they're sitting up, they're smiling, maybe they're playing with a toy in the back of the ambulance, and their circulatory isn't. But remember that that airway is as small. So a pediatric airway is as small as your pinky finger. So my airway is about, I would say my airway is probably 6.5, a 7. Now you take a pediatric airway and you look at their pinky finger, and now we add stridor to it and we add croup or croup to it. That airway actually has swelling in it. And with that swelling, it gets worse and worse and worse as time goes. Cool air, we know cool air makes a huge difference as well. So let me work over here. Circulation. So when we look at circulation, that's something that we really want to pay attention to. Circulation to the skin reflects general blood perfusion throughout the body. So things that we're looking for, we're looking at color and pattern of the skin and the mucous membranes. It indicates, do we have blood or fluid loss to the vital organs? By noting the skin color changes and perfusion, such as pallor, cyanosis, or mottling, you can recognize the early signs and symptoms of shock. And if you have severe bleeding, and a severe bleed, folks, even keep in mind the head. You folks know that if you have a head bleed, a laceration to the head bleeds a lot. You really need to get direct pressure on there and you need to stop the bleed. You folks probably, or I'm hopeful that you have tourniquets, a number of tourniquets. I hope that you have no less than 6 tourniquets on your units. One for each limb, and then a second one if you can't get the bleeding stopped. So pediatrics, you can use those tourniquets for most pediatrics, and yeah, sometimes you have to be creative with it, but the stop the bleed is a huge one that we need to pay attention to. So when we look at circulation, another thing that we look at circulation is our temperatures. So we're looking at 23 degrees here right now. I think it was like 18 degrees when I came in this evening. We have to be careful of when we're looking at cap refill. Cap refill in a cool environment, we're not going to see a cap refill that's going to be something that we're going to pay attention to with a child, unless that child is in a normal heat environment is what we need to pay attention to. 5 patterns of the components that you'll determine. First of all is you need to know your normal heart rate for your ages, and you need those references. And folks, I can't remember this. I've been doing this for a long, long time. I still need resources for that, and those resources come in very, very handy for that. So you have resources. There are a number of resources. I will challenge you, first of all, that you have your EMS for Children little booklet, and that little booklet that you got is your communication aid. Where is your communication aid? Is it in your pediatric bag, or should it be on your bench? So not only can you use this communication aid basically to talk to nonverbal children, but when you get into that pediatric communication aid, we have a whole bunch of resources, and those resources that kind of come in handy, those resources that come in very, very handy are the fact that when we look at critical incident stress management, we'll be redoing that one as well. Suicide warnings, it covers everything from suicide to human trafficking, behavioral health, child abuse. Look at those and have those sitting out. And then the other one is, if you have a need for, these are nurse badges. If you folks have a need or want the pediatric vital norms over there on the right-hand side, it's basically a smaller rendition. Both of these pieces, or both of these resources are on tear-proof synthetic paper. I say tear-proof because we as EMS, we can basically destroy a bowling ball if we're moving quickly. And they are fluid resistant, so you can just wipe whatever fluids off on it. It's easy to keep it clean. So if you don't have some of these resources and you need these resources, please reach out to our office and we'll get them to you. With that, when we look at performing ABCs, we did the what's your quote, and then we talked about the PAT. So when we look at circulation, there's some things that we need to pay attention to. Those things that we need to pay attention to is heart rate. When you're taking the heart rate for a child, you need to feel for a pulse for at least 30 seconds. And then you double that number. If you have a newborn, or if you've had the privilege of being at a birth, sometimes getting that heart rate is very, very difficult. The way that I would encourage you to do that is once that baby is delivered and you clamp the cord, and you're going to clamp that cord up a little bit higher, take your finger and feel the top of that with your gloved hand. And as you feel it, tap it out and tap it out, and have your partner count the number of heartbeats that you actually have. So the other thing that we want to do, we know that our normal heart rate is between 60 and 160. So 60 to 160. It all depends on age. We look at our radial and brachial pulses. That's the preferred site for infants and children. Carotids are really difficult to get in there for our kids. With our children, little fat chins and little no necks and things like that, that carotid pulse is not a good place to get it. Carotid pulse in older kids and teens, but not for infants again. And then we look at our femoral pulses for neonates and infants. We're also looking at the pulse quality. Pulse quality is super, super important here as well. A strong central pulse, so that's your carotid pulse, your femoral pulse, or your brachial pulses in infants, and a strong peripheral pulse for children and teens. That would be brachial, peripheral pulses, your brachial, radial, or pedal pulse, suggests that they have a good blood pressure. So similar to what we do with an adult, when we are treating an adult and we've got a good radial pulse, we make an assumption that our blood pressure is above, or systolic blood pressure is above 80, maybe even 90 is what we're suggesting. When we look at that, we look at strong central pulses. So if you've got a strong central pulse and your peripheral pulse is weak, they're compensating. Somewhere along the way, they're compensating, and the reason they're compensating is they're shunting blood to the vital organs. If you have a brachial pulse that's not palpable, that brachial pulse might not be palpable. Your child is either hypotensive, hypovolemic, or hemodynamically unstable, if that makes sense. Skin temp, we talk about that again. We want to check skin temp at the hands, the feet. You can even check it at the kneecaps and the forearms. One of the things for you folks to kind of keep in mind is if some of you folks are at the advanced AEMT level, or you are starting IVs and you have a kid who is hemodynamically unstable or hypovolemic, we need to fill their tanks, and we need to fill their tanks quickly. When we're filling their tanks and we're trying to fill them quickly, what you'll find is when you're doing fluid boluses, you may have a kid that is basically kind of dumped out. The more that you get fluid into them, as you move up, you'll feel that their feet might be cool and they might have cyanosis to them. And as you move up and as you fill their tank, much like your gas tank, and that tank goes up, basically, that hemodynamics, so then their legs will warm up, and then their belly warms up, and then all of a sudden you've got a kid who is alert and they've got a good mental status because you filled their tank back up. Okay. We can talk about that cap refill. Cap refill should be less than 2 seconds in children that are in a normal environment. Not the best time to do it when we're out playing, and maybe you have a kid who is sledding and is knocked unconscious or something on that order. That's not the place to do your cap refill. You can do cap refill for kids on the top of the feet, the little chubby babies on the top of the feet, on the top of the hand, just kind of pushing down and waiting and counting until that color returns to a normal. We talk about blood pressure. Blood pressure we don't typically like to do on kids. So here's kind of one of the things that I want you to keep in mind. Infants less than a year should have a systolic blood pressure of greater than 60. You attempt a blood pressure in children less than 3 years of age one time. It's critical for you to make sure that you have the proper cuff size. So you want to use a cuff with a width that's 2/3 the length of the upper arm. So you don't want a cuff that's too big or a cuff that's too small. If you have a cuff that's too large, then you're going to have a decrease in blood pressure, and you might be given fluids or something that you don't need to give, and you'll throw a kid into congestive heart failure. Or if you have one that's too small, then you're going to have an increased blood pressure, and you're going to be wondering, well, is this an intracranial pressure, or is this something else? So basically, we'll take our blood pressures. Normal systolic blood pressure for kids is going to be Normal systolic blood pressure for your kids is going to be 70. And then we add 2 times years and age. So your normal blood pressures will fall right in there. So you want to keep that in mind. Hypotension is an ominous sign. So if you have a child who has a blood pressure lower than 60, especially an infant lower than 60, you better be moving. And you hopefully have a plan on how you're going to treat that child. Other things that you want to keep in mind, you also want to get your sample history. That'll tune you into what the child may have going on for any cardiovascular problems. And then you'll do your QRST as well. Again, here's your tools and your resources. Your tools and your resources, these are the tools that we provide for you. With those tools that are provided for you, the Broslow tape, one of the things that I'll ask you later on in this survey is, what version of the Broslow tape do you have? Do you have the 2017? Do you have the 2019? I believe everyone should have at least a 2017 version with the number of grants and things that we've received. So we'll talk about some other things here moving forward. We're going to talk about bradycardia. What is bradycardia? Bradycardia is a slow heart rhythm. So when we look at bradycardia, it usually reflects hypoxia. So what's hypoxia? Hypoxia is basically we're not getting enough oxygen. And then hypoxia reflects hypoxia rather than cardiac. It is a pre-arrest rhythm. Folks, if you have bradycardia on your monitor or you feel for a pulse and it's a super slow pulse in a kid, now take in mind, we've got a kid who maybe is a cross-country runner. We have a kid who plays football. We have a kid who does any of these things. That may be a normal rate for them, 60 or below. But any of those kids who have low heartbeats below 60, they're going to dump on you and they're probably going to arrest on you. So you want to make sure that you're already treating that. Ventilation is our biggest goal right there, is to get them ventilated. So it's a pre-arrest rhythm, guys. It's kind of like when you look at TIAs. This is giving you a heads up that something is wrong and you need to do something quickly. Get your bag valve mask out. If you don't have your bag valve mask out, get your O's on as quickly as possible, non-rebreather, and then get them bagged up. And hopefully that'll keep you from going down that road with an AED and then having to shock and all of those things as well. Asthma and respiratory distress, that's profound hypoxia. Use your O2 sat monitor. A lot of times though, you folks have the experience, and with that experience that you have, what you're going to find is that you have your O2 sats maybe 100%. If you have the capability, and most of you folks do, you have the capability, put your end tidal on. Your end tidal with that nasal cannula, it is a great resource. So when I look at asthma or I look at respiratory distress and I find somebody that is asthmatic, one of the first questions I'll ask is, have they ever been intubated and have they been in a hospital for a long period of time? If you put that end tidal CO2 monitor on them, normal end tidal CO2 is 35 to 45. If they're up there and they're up in the 70s or 80s, these kids are going to crash on you, or even your adults are going to crash on you. And it's going to happen very, very quickly. So it's something to kind of keep in mind. You may need to use their rescue MDI, which is their metered dose inhaler, or depending on if you're ALS or BLS, it all depends. Drug overdoses, when we look at drug overdoses, that's bradycardic as well. We do see a lot of drug overdoses with beta blockers. So beta blockers are anything that starts in an OLOL. So metoprolol, atenolol, any of those can be out there. You look at calcium channel blockers, digoxin or dig, clonidine, they all cause bradycardia. With that, you want to refer to the Poison Control Center for your emergent treatment, or follow your local protocols. All depends if you are ALS or BLS, but don't be afraid to call the Poison Center, so at least they can get things moving as far as the best treatment for any of these drug overdoses or potential drug overdoses that you have. If your heart rate is below 60 beats per minute and the child shows signs and symptoms of poor systemic perfusion or ventilation, you want to assist those ventilations. And if it continues, then that's when you start your chest compressions. Those of you who are in ALS, that's where you're going to use epi as your first line drug. So you're going to use an epi, the 0.1 milligram per milliliter concentration, and then you will give it 0.01 milligrams per kilogram. So it's something to kind of keep in mind that you're going to be treating this and treating it very quickly. Again, bradycardia is a pre-arrest sign and symptom. I'll give you kind of a scenario that I had, and this is an adult one, it kind of deviates off the pediatric world, but I had a gentleman who he ran a horse ranch, I guess, for lack of better terms, or a little dude riding ranch for kids. And what he would do is he would drug his horses. And so we get a 911 call in the evening. Casket down. We run a 911 call in the evening, and as we run it in the evening, we get there. The guy is sitting there and his family saying he's not acting normal. So we started asking him questions. He's answering questions very, very slowly. As we roll his flannel shirt up and we're getting ready to do a blood pressure, he's got like 3 or 4 rubber bands tied around his arm. And I asked him what he did, and he used the sedative that he used for his horses. He used it on himself. So he was very slow. So he had a heart rate of 60, 60 and less. He had a blood pressure. He was slow to answer questions. Get him in the back of the ambulance, and we're transporting him. And like, dude, if your heart rate goes any lower than 60, I'm gonna have to start jumping on your chest. And he's like looking at me. He stayed stable the entire trip that we had. We had our atropine out, we had our defibrillators, pads on him, we had everything ready to go for him. But the antidote for him was something that we did not have on the truck. It was something that, so obviously you guys know that I was in North Carolina. We had to call it in, and Duke had to find a special antidote for that particular drug that he had taken. So anyway, not everybody needs to have chest compressions just because their heart rate is lower than 60. We look at the next one we're going to look at is we're going to look at tachycardia. Oh, I jumped ahead of myself a little bit. So tachycardia, we look at tachycardia. Those are those fast heart rates. Those of you who are into muscle cars and things like that, we have tachometers. Tachometers basically kind of give us an idea of how fast something is going. Tachycardia can be caused by a number of things: fever, pain, anxiety. Those all can kind of fall into that tachycardic rate, and they can bring your rate up. There's some things that we want to pay attention to. Life-threatening problems. When we look at life-threatening problems, we look at hypoxia. We can fix that with oxygen. Hypovolemia, we can fix that with fluids. Or is it cardiac related? Is it something that we've got some kind of a cardiac event happening? Sinus tachycardia is the most common sign and symptom that you're going to see in kids that are hypovolemic. The treatment for that is 20 cc or 20 milliliters of fluid per kilogram over 5 to 10 minutes. So those are those fluid boluses that we're going to give them, and they need to have their tanks filled quickly. So you fill that tank one time and you check your vitals. You fill that tank a second time, you fill the vitals. How many fluid boluses do you give? You give enough fluid boluses to these kids until they are normal, so that they're back to where they need to be. And don't forget to get a blood sugar in there. So sinus tachycardia, when we look at a heart rate above 220 beats per minute for kids, for those infants, or I'm sorry, excuse me, less than 220 beats per minute for an infant, or less than 120. When we look at sinus tach versus SVT, there's a little cue in here. It's called variability, excuse me. With variability, they won't have variability if it's an SVT. The reason I say that, so sinus tachycardia, you're messing with an infant or you're messing with a child, and you put a cold stethoscope on them and you look at that monitor, and that rate goes from 220 and it drops down to 200, or maybe it drops down to 190. If you have a kid who's in SVT, you put a cold stethoscope on them, maybe you start an IV on them, maybe you move them from point A to point B. It's not going to be a variable rate. It's going to stay the same across the board. Okay. So it stays the same across the board. And then we look at VTAC. That VTAC that's a serious systemic illness. There's something going on. Those moms, those new moms, we get very, very jaded when we've been in this business for a long period of time. And when we've been in this business for a long period of time, oh yeah, it's just a new mom and she's calling about her baby and her baby's not feeding well. Or maybe the baby had projectile feeding and he's kind of fussy and he's cranky. You need to get a monitor on these babies. SBT is not uncommon in pediatrics, and it typically happens, so it's not immediate, but it's not a long process. So when we look at SBT, we look at SBT as, I would say, anything that starts within 4 hours. So you've got a 4-hour time frame. That is kind of, it's not a chronic condition. It's a condition that basically happens over a short period of time. SBT is super serious, folks. With that, you can recognize SBT. You can use some bagels. That bagel would be probably ice to the face. When you're looking at ice to the face, when you're doing ice to the face, you're going to be putting it basically right above the head, right across even the bridge of the nose. The bridge of the nose, when you have the bridge of the nose, that will actually cause a baby to vagal down, but you definitely don't want to smother somebody. So you want to make sure that you're using your ice appropriately. If they're stable when they're in SBT, if they're stable, we're going to use adenosine for that. And unless they have Wolff-Parkinson's white, then we wouldn't be using it. And then we can also use synchronized cardioversion for those kids who are unstable. The whole goal of this is to get that heart rate down. It's not uncommon for little ones who are out there that they would have a heart rate in SBT over 260, 300 beats per minute. That heart is moving fast. One of the things that we need to pay attention to is lung sounds. Listen to lung sounds, because what's happening is the heart's beating so fast that it's not moving out of the lungs. Fluid boluses, if you are giving a fluid bolus to a child who is in SBT, you're going to drown them, because it doesn't have the heart does not have the capability of moving it out, and you will cause congestive heart failure, and you cannot pull that fluid off fast enough. So that's something to keep in mind. At a BLS level, you're either going to call for a helicopter, you're going to call for an ALS unit to basically meet you there, or depending on where you are, you're going to get to the hospital as quickly as you possibly can. So if that all makes sense. Other things that we look for is our complexes. I hope you folks are using your monitors to your best of your abilities. They are phenomenal tools. Get your pads on. Even if your sticky pads are big pads and you are putting big pads on a tiny little baby, that's okay. It may take up half of their chest as far as monitoring their heart rate, but it's a great tool, and it takes one of the stressors away from you. So use that as a tool versus not versus struggling, I guess, is the best way that I want you to pay attention to. Pay attention to Tegretol. If a kid is on Tegretol, it does have the capability of causing some issues as well, especially when you're looking at VTAC and things on that order. Chain of survival, when we look at our chain of survival, prevention is probably our biggest one. We can do a lot of preventative things. I'll start with drowning. Drownings can be prevented. Not taking your eyes off your kids, they'll zip off and very, very quickly. Not leaving them in the bathtub. There are other preventative things that we can do, making sure that they're restrained appropriately, making sure we have a lot of prevention programs that are in our office, and I'll kind of go through those a little bit later. AEDs and your cardiac monitors. When you are looking at your AED, a cardiac arrest in children is the result of hypoxia or shock, which leads to either asystole or PEA. Asystole, if you have a child who is in asystole, and asystole is that flat line, I call it a very stable rhythm, you most likely are not going to get them back. If you have PEA, PEA is pulses electrical activity. That's where you go back and you look at the H's and T's. There are a lot of things that we can fix with the H's and T's. Are they hypovolemic? They need fluid. Are they hypoxic? You can give them oxygen. Do they have low blood sugar? We can give them D50. There's all kinds of treatments in there. If you're using your AED, folks, or your life pack that you have, or maybe you have a Zoll monitor, get your patches on. If you don't have pediatric patches, or somebody didn't replace the pediatric patches, that's not the time to get upset. What the time is what do you need to do next? So what we're going to do is we're going to put patches on the front and the back. So we'll put a patch right directly on the front in an infant's chest, and then we're going to put it right on the backside on the backside. So that's placement's just going to be like this. Make sure when you got your cords, folks, if you're doing chest compressions, you want your cords kind of to the side. Your hand, if it's rubbing on those cords, you're going to rub a hole not only in your glove, but you're also going to end up with a major blister on your hands as well when you're working these kids. So try to keep them either to the side or down towards the lower part. Always keep your monitor at the top of the head. Whoever's running that monitor is in charge of that monitor. We looked at VFib. We talked about VFib just a little bit. We do have VFib, and we do see it. It's not usually in the infant age group, but we can see it in the older kids. When we look at VFib, and I can go up VFib or VTAC, either one. Whoops, I'll go back up. So when we look at VFib or VTAC, myocarditis, there are some things that kind of come with that. Myocarditis is infection of the heart muscle. Long QT syndrome. We had a little gal that we flew a few years ago. She was at the lake with her friends. She was standing on the dock. Her friend was messing around in the water, and when they came back up, then what happened was she was no longer there. And they fished around for her. They found her at the, she basically fell off the dock. And when she fell off the dock, she was face down, mud in her airway, her ears and everything. The blessing of that was PD was not far from her. First time he'd ever used his AED, he lit her up with the AED and he saved her life. And then we flew her, she had long QT syndrome. Long QT syndrome is a congenital problem. As we did more research, I was able to follow this little girl from the flight, and then I flew her again to a specialty hospital where she got a defibrillator as well as a pacemaker. And her mom also had long QT syndrome, and then her grandfather had died in his early 40s and 50s, and the assumption was that he had long QT syndrome as well. You also hear about the comatose that's where we hear about athletes who are struck in the chest. Usually it's right in the center of the chest, kind of right over that left ventricle. It causes a whole lot of issues. They get struck in the chest, and then the left ventricle basically doesn't have the capability of pumping blood, and it causes a lot of issues with preload and stuff. Sudden infant or sudden unexpected infant death, infection, maltreatment, respiratory failure, and then we also see it with our older kids with hemorrhagic shock or blunt trauma. So those are things to kind of keep in mind when we're looking at that. I'm going to move back down pediatric chain and then our pad placement. We talk about the Lucas device. I wish I could talk to you folks and get a little bit of feedback. So what I want you to pay attention to with your Lucas device is Lucas and kids. Can you use a Lucas device on kids? The Lucas device, what I want you to do, so I looked up our protocols for the state, and it doesn't specify. What you're going to do is you're going to follow manufacturer's directions, or you're going to follow your protocols. So whatever your medical director has for your protocols, you want to follow those. So one of the things that you're going to do, so you know that the Lucas device, it's going to be a two-person thing. I don't know when the last time you guys pulled out the Lucas device. I encourage you to do it. Again, this pandemic has taken away our muscle memory, and the things that we did very fluently and did very, very well, maybe in 2019, we're not doing so well because we haven't had our hands on it. So we need to get our hands on these. But when you take that plunger and you pull that cylinder down to the chest, when you pull it down to the chest and it actually starts to alarm, that patient is too small. You can't use the Lucas device on them. If you pull it down and the distance is the width of your hand, which is about 15 millimeters, which is about a ½ an inch, that ½ an inch that you have when that cylinder is there, that cylinder will actually push down and you can actually use it on your pediatric patients. So when we look at a 6-year-old, a 7, a 14-year-old, you can use that Lucas device on those kids, depending on the size of a kid. Again, it's common sense, folks. It's not just the fact that we are using the Lucas device to get us by with something that we may or may not use. Lucas devices fail. So if you have a fail and you replace the battery and it fails again, you go back to chest compressions. We rely, and the chain of survival is early CPR, good quality CPR, and BLS folks, they do it and they do it the best. They do it better than anyone else. Okay. So we talk about the Lucas device. Make sure that you folks are getting it out, that you're practicing with it. I can guarantee you folks, after we do this pediatric cardiac arrest, there's going to be somebody within this group that is going to have a pediatric cardiac arrest. You're going to be using the Brazel tape. You're going to be using your resources. You're going to be either using the Lucas, you're going to use the defibrillator. And then you're going to call me and you're going to go, oh my God. So get that equipment out, guys, because somebody within this group will be working it within the next 2 weeks. I guarantee it. You know how it goes. Oh, let me move over here. So again, this is the Lucas device. When we look at the suction cup, if that suction cup is on the chest, if it's compressed, it's ready to use. If it's not compressed and you can get your hand through there, then it's too small to use. I bring these forward to you. We do everything kind of algorithmic. We want a rhythm when we're doing a sample history, when we're doing a medical history, or we're doing anything. We use algorithms, folks. And a child who's in bradycardia, these are the new 2020 updates. And with those 2020 updates, what our whole goal is bradycardia, or that low heart rate. Anything below 60, we want to make sure that we're paying attention to what's going on. We get oxygen on board, you support it, you get a 12 lead. If you can get a 12 lead on these kids, you maintain your airway, you start CPR if it's less than 60, and then if it persists, then you either need to call for ALS assistance, or if you have the capability of delivering drugs, then you follow that rhythm. When we look at tachycardia, so we talked about tachycardias, we talk about VTAC, VFib, VTAC, you can have VTAC with a pulse or VTAC without a pulse. You can have just a tachycardia, and you can have SVTs. And there's rhythms that you want to follow with that. It's recognition. Don't let these things scare you, folks. That's what I'm not trying to do. Is I'm not trying to scare you. What I'm trying to do is to interest you, get you interested in, maybe rhythm recognition isn't your forte, but you can tell fast and slow. And if you have the capability and you're sending your strips in and you're sending them to the hospital, or you can call in and you can tell your doc, hey, I got a heart rate of 220 and this kid is 7 years old. Okay, he's 7 years old, and then you do a little bit more of a history. He's 7 years old. He walked home from school. He decided to stop off at the gas station, and he picked up a Monster and he drank a Monster. Well, you know that he's going to be tachycardic from that. But those rhythms have to change. He can't maintain a 220 beats per minute. We need to get fluids on board to start flushing that out and things. So those are things that I just kind of bring forward to you. Let's see. And now our key one. So we talked about pediatric cardiac arrest. The 2020 version we have going here, and early CPR, folks, you want to get your CPR on board as quickly as you possibly can. So it's good CPR. It's recognizing that, not stopping CPR basically to put the monitor on. As EMS folks, we are used to being in one another's space. When you get into somebody's space, you can work around, you can put a patch on the front, you can roll, you talk to one another, you can roll that patient forward, backward, and the sooner you can get that shock on board, the better chances that we have of saving that child's life. That's for VFib or pulseless VTAC. If you're in asystole or PEA, you're not going to get a rhythm. Again, with asystole, I call that a stable rhythm. That's that rhythm that's going straight across the board. It's a flat line. Most likely, we're not going to get that child back. I don't know what your protocols are individually for your agencies. I would encourage you to look at them. And if you don't have them, what do you do? If you have a child who is asystolic on scene and maybe it's sudden infant death or a sudden unexpected death, do you leave that child there, or do you transport that child? So can you call it on scene? And for heaven's sakes, folks, if you have a child and you lose a child out in on the scene, you need to stay with that family. You need to stay with that family. You need to be there with PD. Again, I get it, and I know where we come from. We're small town USA. Most likely we know that family. We call the minister, we make sure that the coroner's coming in, but your documentation is so, so critical. Pay attention, don't get too tunnel visioned on what's happening and what happened. So sudden infant death syndrome for primary example, or SIDS, or any of those things, or maltreatment. When you roll a baby over and you notice that they've got the white marks basically maybe from their hand. So as I push on my face, you can see that I'll have that white mark. You note that. So when you roll that baby over, what's going to happen is that's going to go away. And that helps the coroner have a better idea. So those all need to be documented. All those things need to be documented. If you're looking at maltreatment or any of those things that kind of come with that, pay attention to that. You know, I had a case that we flew up north to, and it was a two-year-old patient who had documented impetigo. So impetigo, as I know impetigo, basically is the nose and the mouth, and they get this little scabby, yucky, gross looking thing. But this impetigo was diagnosed and was peripheral. So we had impetigo on the legs, we have impetigo on the arms and stuff, and this just didn't feel right. And as we got there, the more I had the opportunity to look, so I was in a helicopter and flying back, I noticed the round circular little marks. They weren't impetigo, they were cigarette burns, and this child was abused, and we did lose that child. It's a horrible, horrible case. And there are some key changes that we need to pay attention. Those key changes that we're looking at for 2020. This is there's a lot of controversy going on with this because they only did the study on about 47 patients, is that we're increasing our breaths from 10 breaths per minute, that we're increasing them to 20 to 30 breaths per minute. So that's one breath every 6 seconds that you would be doing. Now we're going to 20 to 30. Common sense, folks, again, it becomes about common sense. If you are working a cardiac arrest on a kid, if you have the capability of end-tidal CO2, put that nasal cannula on there, plug it in, watch your end-tidal CO2, 35 to 40 is normal. You can even use it for head injuries. You can use it for asthma. You can use it for so many things. And you're bagging that kid. We want to make sure that we're keeping them in that 35 to 45 range is where we look at. If they're below that and you're doing good chest compressions and you're doing your shocks and everything appropriately, and all of a sudden maybe you were at 10 at your end-tidal CO2, and now your end-tidal CO2 jumps up to 25, and then it jumps up to 30, you have return of spontaneous pulses. Those spontaneous pulses, you may not be able to feel them, but the end-tidal CO2 picks it up. So that's your friend. It doesn't cost a whole lot to get those end-tidal CO2s. It's just a nasal cannula. You pop it on, you plug it into your monitor, and it comes up. And if you don't have that capability, you guys got fancy, nice little monitors through Mission Lifeline. Utilize your equipment and utilize your tools that you have, but don't focus just on your tools. So before we were doing 10 breaths per minute or one breath every 6 seconds. What we worry about is that interthoracic pressure. So when we increase the interthoracic pressure, what's happening when we're going up to 20 to 30 breaths per minute is we have vasoconstriction that's going on. So we have vasoconstriction that's going on in the cerebral blood vessels, and then it also reduces the capability of the right ventricle to fill. So things to kind of keep in mind. Again, I talked to you about some of your resources, and we'll do a quick little case presentation. Everybody with me still? I know I'm kind of going overtime. You're dispatched to a middle school athletic field for a child with loss of consciousness. You got a 12-year-old lying on the floor. They are doing CPR on him. Teacher said he collapsed while running laps around the floor. What do you do? First of all, is he sick or is he not sick? We know that he's sick, okay? And with that, some of the things that you want to pay attention to, we'll move forward with that. His appearance, he's unresponsive, he has no respiration, and he's pale and he's cyanotic. Okay, so with him being pale and cyanotic, we're going to continue the chest compressions. We're going to get our AED up and rolling as quickly as we possibly can. If he's in a shockable rhythm, we're going to get him shocked as well. So general impression, he is a sick little guy. he's in cardiopulmonary failure. So in that PAT or that pediatric assessment triangle, all of those are going to be filled in. So you're going to have red, 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 red. So he is very quickly, you're going to be able to assess that. Start with your bag valve mask, get your AED on board. So airways patent, no chest movement, circulation, disabilities, unresponsive, and he has no bruising or signs of injury. And with that, with the no signs of injury, make sure that your chest compressions are good. Chest compressions are really vital. Not too deep, making sure you're coming off that chest and letting that recoil actually happen. That heart needs to fill back up. And I know it's really easy, folks. I've been on those pediatric calls where you're pumping away and you're breathing just as fast as what you're pumping. You've got to come up off of that chest and allow that heart basically to refill so that we can get blood perfused to the brain and to the body as well. We're going to say that this little guy's in VFib, cardiac arrest, trauma. Did he have a direct blow to the ventricle? Does he have toxins or drugs on board? Did he get into something that he shouldn't have? Does he have an acquired heart disease that we don't know about? Or does he have even a primary cardiac disease? We don't know. We just manage what we have in front of us. So probably not so worried about that. Is what we need to do is manage that. It's CPR, AED, and shocking. Analyze your shock. Again, make yourself very, very, very familiar with your monitors. I don't know when the last time you've worked a code, either adult and or pediatric, and get your compressions on board and then reanalyze and shock if you need to shock. If you don't have a shockable rhythm, you continue chest compressions. And with that, follow your local protocols. If you have the capability of calling a code, then you're going to call the code. That would not be something I would do without a medical director or medical director from a hospital. ALS, you're going to manage this. You would start an IV, you would put a tube in, the tube would come after you would start your IV, and an IO is probably what I would go to first. And then I would use my epinephrine. And then reassess, and then you start your defibrillation out. So you're going to use 2 joules per kilogram, then you'll go up to 4. So you can go 2, 4, 6, and 10 if you need to. And then if you're going to do a vasopressor, which is going to be your epinephrine, and then an antiarrhythmic for VFib would be amiodarone is our first drug of choice, which is 5 milligrams per kilogram. Transport decision, obviously we know we're going to transport those kids really super fast. Airway management, that's critical. And then VFib is very uncommon for kids, but you need to recognize it. Early defibrillation and early CPR are our biggest chances for these kids to survive this. High-risk groups for that are the cardiomyopathies, post-Kawasaki's disease, aneurysms, thrombi. We look at kids who may have sickle cell anemia. We also look at the kids we're calling MISC, that's with COVID related, and the clotting factors that we see with COVID. Something to kind of pay attention to kids. We're not seeing a lot of kids with the MISC related to COVID. I think there are Petri dishes, a little more resilient. If they have a direct blow to the chest, or if they have even some kind of dysrhythmia syndromes. Rescue breathing again, vascular access if you can, and you reports 3 brief episodes mom does of exercise-related syncope, sudden death at the age of 28 of an uncle. So that gives you an idea that it's long QT syndrome, very similar to the young lady that I was referring to that fell in the water face first. She had a long QT syndrome, and then they get a pacemaker and they go from there. So high risk, again, we talked about that. The summary, basically, my whole goal for you in cardiac arrest, regardless of what it is good CPR, knowing your equipment, knowing where your resources are, getting that Brazo tape out. That Brazo tape helps if you're calling a helicopter, it helps with your ALS. And when you're making that call in and you're letting the staff know that you're coming into the emergency department and you have a kid that measures a purple on the tape, that gives them the ability to pull all of the equipment out of the purple drawer, and they're ready to intubate, they're ready to put an IV in, they're ready with the appropriate sized IO, everything's ready to roll. So that Brazo tape is super important. So we talked about pediatric skills and scenarios. So I talked about pediatric champions, and I asked how many of you are pediatric champions. If you do not have a pediatric champion within your ambulance service, I ask that somebody steps up to that plate. It's not that you have to do all of the work. What you're doing is basically making sure that we're doing that we have equipment available for our pediatric calls, that maybe we're onto training. So for primary example, I'm a member of the HEC group, which is the Heartland EMS for Children group. We've been putting on quarterly trainings. This is a training. If you have a training, you bring that to the attention of your squad members. We make sure that we're doing Q&A, that we're doing a better job taking care of our kids. Maybe we're doing safety and injury prevention programs. We have a lot of safety and injury prevention programs right within our EMS for Children service here as well. Again, I have 87 folks. My pediatric champions, for those people who stepped up, those folks received the pediatric skills and scenarios. Perfect timing. It comes out in 2019. In 2020, we get hit with the pandemic, and with the pandemic, a lot of things are closed down, but we're seeing a lot of our ambulance services have their in-house meetings and things. You folks, if you take a look at the way that this is situated, so the way that I have it is you are able to do a scenario, and this is your checkoff sheet. Each provider does a checkoff, and with that checkoff sheet, you have scenarios. So that scenario is there right in front of you. It doesn't take a rocket scientist to work your way through a scenario. It's something that either you as the pediatric champion, if you're really passionate about pediatrics, or whoever your training person is, I've got your instructor set up notes. What do you need? You need mannequins, pediatric bags. If you guys need equipment, I have the capability of sending five pediatric kits out there for you to use if you're doing a specialized training night. So it's, I got a huge bag full of pediatric equipment. I've got boxes, they're Pelican boxes. They're ready for your use. All I ask is that you return the equipment in the way that we had it. So that scenario gives you the idea that it's code blue. It gives you the focus center of care. Again, it brings up your vital signs. So all of the vital signs, if you miss something, this kid weighs 40 kilograms, so he's probably coming off the Broslow tape. It even shows you how to measure for a kid in the appropriate weight range. And then we talk about additional considerations. Do you have family-centered care? Family-centered care basically you're including the parents. Especially with children with special health care needs, they're the experts. You are not the expert by any means. Even as a medic coming in, I am not the expert. These parents have been with their children from day one. You ask them how to best treat their child, and they will basically walk you through it. And let's see. So I talked about the Heartland EMS for Children Coalition. Some of you folks may have had the opportunity to join us early September. We did human trafficking. We did human trafficking related to pediatrics. And with the pandemic, if you don't think that human trafficking is happening right now, it is hot. It is a hot topic, and it is happening everywhere across the country. We are seeing more and more human trafficking, and we're seeing more and more child abuse. Heck, that's what we call ourselves, the Heartland EMS for Children Coalition. That is South Dakota, North Dakota, Minnesota, Iowa, Kansas, and Nebraska. So we all work together. We're all EMSC managers, and we all work together. With that, we bring you Kids in Crisis. So Kids in Crisis is coming up on March 11th. And that will be basically how do we take care of those kids who are either having a mental breakdown or a behavioral crisis. So how do we walk those how do we walk through and de-escalate those situations? And then once we de-escalate those situations, then Dr. Cedars is going to come in, and she's going to teach us about how do we do psychological first aid for these kids. So not psychological first aid for you as the first responder, it's psychological first aid for the kid, and how do you move and transfer and move that through so that we can get these kids calm down a little bit. That registration you're going to find, I'll send it out to all EMS agencies. This includes CMEs, so we can get your docs on board, CNEs, we can get our nurses on board, and then our CEUs for our EMS personnel as well. And we've done that for everyone. It's a no cost. If you register, we ask that you show up and then go from there. But it's been very, very successful for us. Want to introduce you with Diane Hall. Diane Hall, a number of you folks are very familiar. So we have a number of safety and injury prevention programs. The bike and pedestrian. So bike and pedestrian, that is the don't thump your melon. Safety and injury prevention. We talk about safety and injury prevention again, and that safety and injury prevention, when we look at that, if you are in need of bicycle helmets and you are wanting to do a bike rodeo or just some kind of a training to make sure that these kids aren't thumping their heads, that's important. Pedestrian, believe it or not, folks, is it's on the rise. So even with the COVID, it's even more up. We have more pedestrian fatalities and injuries in the state of South Dakota than what you folks even realize. It's not just the 2-year-olds, it's not the 5-year-olds, and it's not the 14-year-olds. It's the 50 to 60-year-olds that are getting ran over as well. Pedestrian fatalities are higher than our bicycle injuries that we have in the state of South Dakota. Diane has some great occupant restraint programs. It's not fine until they're 4'9", is one of her programs that she has. That's keeping kids in booster seats. We have a big focus on making sure that our teens are staying buckled up and that kids are staying buckled up, the protected, not ejected. And then also Diane is in charge of the Sanford Poison Education and Resources. So any of those resources that we have, we got an exciting venue coming out with the poison end of it. We have a little boy, it's an actual case, a little boy named Henry. He was up from up north as well. And Henry accidentally got into, he was accidentally poisoned. Dad had stored some gasoline in a Gatorade bottle. And I know everybody's got their garage and there's a bottle in there that you are storing something in that you shouldn't. And Henry took a sip of that. And of course, then he ended up in the ED and the story just kind of progresses from there, but it's a really great story. And we're going to be introducing that hopefully within the next month or two. And then we welcome Miss Jamie Bartell. Very blessed to have Jamie on board as well. Jamie is in charge of the impairment grant that we have. She'll be moving that forward. So impairment is not just alcohol. When we look at our state of South Dakota and where marijuana is going to take us as far as medical marijuana, impaired driving, when we look at that, it's drug driving. So when you look at the number of folks, whatever age that they are, if they're not themselves, it could be THC, it could be that I'm on painkillers, it could be any of those things. That's impaired driving. So Jamie heads that one up. She's got a really great campaign coming up for prom. Her campaign is actually, it's a really cute campaign. It was to the point where I was actually testing it out and I was walking in circles, and you'll kind of find a little more out about that. We're going to move that impairment campaign through the FCCLA groups within your school system. So that's an opportunity for you as parents and grandparents to get involved. Jamie's also in charge of the pediatric safe transport. So pediatric safe transport, our goal, we are working on, first of all, we have a survey out there for EMS agencies to see what you have for pediatric restraint devices. We want to make sure that these kids are being appropriately restrained in your vehicles or in your ambulances. Actually, it's a state law, folks. It's a passenger vehicle. And then we are also promoting that you are restrained as well. We're not so busy that we can't be restrained. And if you honestly think about it, folks, so I put a helmet on and I put my 4-point harness on when I'm flying in a helicopter, the chances that I'm going to survive a helicopter crash are pretty low. We should be putting our seatbelts on when we're in the back of an ambulance. So Jamie's going to head that up and spearhead that up. And then she's looking for funding for our ambulance services so that we can get some pediatric restraint devices out there for you folks as well. And then she's also my right-hand gal for EMS for children. I get her about 20% of the time, of which I have desperately needed her. So we're very happy to have her in the office. And she came in and she hit the floor running. So I think a lot of you folks, if you're from up north, you are very familiar with Miss Jamie. Pediatric emergency care, we talk about pediatric emergency care champions. I talked about the PEC perks. So that PEC perks is basically you're going to be alerted first. It's kind of like that blue light special that we used to see in Kmart. We're still putting together the program, but you're going to have notification and firsthand capability of getting a hold of our resources. If we've got equipment available, you're going to have that equipment. The training is going to be available to you. We're working on a program for children with special health care needs. That program will come to you first. I would encourage you folks to go back to our website. Our website is sdemsc.org. And every one of your services, you folks are PEDS ready. You need to be recognized for it. Take that PEDS ready. It's a quick little checkoff. You work with your medical director. Right now we have 5 services that are pediatric ready, and they've received the Pediatric Readiness Award. And with that, if you have all of the equipment that the state of South Dakota State Office of EMS has, if you're doing your training and you have your CEs for your BLS folks, your ALS group, what else is it? I've not put that you have pediatric restraints in there. You have to have a pediatric champion, so you can sign up to be a pediatric champion or have somebody sign up to be a pediatric champion. Good Lord, guys, I feel like I'm talking so fast, but they're really great things to bring to your communities. So when your communities, when we're struggling as a community to keep our ambulance services alive, this is a big deal. You make it a big deal by letting folks know in your community. The one thing that we have, the capability in our community is when someone calls 911, you walk into their house, they are open arms and they are willing to give you whatever you need. You need to bring that up to your folks who are your commissioners, who are your leaders within your communities, and lift your services up and let them know what you're doing. You're the only one that can do that. And your ambulance services are vital to your communities. They are so vital because you look at geographically how large the state of South Dakota is. And then we start looking at, we have 66 counties in the state of South Dakota. 31 of those are, I think it's 31 or 33. 31 of those are rural and 33 are frontier, or maybe vice versa. We are a very rural and frontier state. So lift it up, lift these projects up and put them out there and let folks know what you're doing. Surveys, I've got 4 surveys out there. So with those surveys, we're doing one for the National EMS for Survey. Please go back and ask your either your president, your director, or whoever, if they've completed this survey. It's a super simple question survey. You can either use the QR code, use the QR code, pull it up on your phone, and do it on your phone. There's a couple of things with the National EMS for Children survey. You'll want to know how many calls you ran last year in 2020. You'll want to know how many of those were adult, how many of those were pediatric calls, and then it's going to go through and there's going to ask you questions about, do you have a pediatric champion? It doesn't ask you if you have a PEC or a pediatric champion per se. It doesn't ask the question straight out, but if you're doing these things and you have a pediatric champion, the answer to number 17 is yes, we have a pediatric emergency care coordinator. That's what they're calling it. Excuse me. The next survey is for non-transport fire and rescue. Non-transfer fire and rescue, those are those folks that aren't transferring. I need to know more about what you have for equipment. I have resources for you. That can be the Broslo tape. It could be the additional resources that I showed you. There are a lot of resources and there's some training available for you folks as well. So if you have a fire rescue service that is not transporting, get this to them. I've had a little bit of difficulty moving this through. I did contact the state fire marshal's office. Being we're a volunteer, most of our agencies are volunteer. It's called PII. So when we look at PII, it's your personal identifiable information, and that information is protected, and we don't want that information to get out there. Not that I'm going to release that information or use it for anything bad, but there's always somebody that is always looking for it. So it's not that I can find your information on the website very, very easily. And so we're pushing it through as best we can through a number of the State Firefighters Association. We're pushing it through the Fire Marshal's office, and then another group of folks are basically helping push that through. South Dakota EMS agencies, I need to know what you guys have. We want to know what you have for pediatric restraints, as far as the appropriate devices to restrain these kids. What's your Broslo tape? We have funding for these resources, and I want to be a good steward of the funding and make sure that we are getting the equipment to the appropriate services. So I ask that you fill out your EMS agency. So that was a two-parter for your services. Right now, we're about 40% of our 127 ambulances that have completed the survey. And then I have a hospital survey out there as well. So if you have a small town hospital, hopefully they're answering it as well. So why do I do what I do? Well, these monsters, so I'm missing one. The youngest one was not there. These are 7 of my 8 grandchildren that I have. That's why I do what I do. I try to lift that up and keep you abreast of that. Pediatric calls are tough, folks. I'm not going to sweep that under the carpet. There's no reason for me to do it. I have calls to this day that will bring me to my knees. They'll still bring me to tears. There's a couple of things with pediatric calls. You need to find yourself, and you need to be busy. And the reason I'll give you this scenario. I don't want to end it on a bad note, but the scenario that I had was I was out in the county, and the station was called Station 8. And Station 8, what happened was a grandmother ran over her 2-year-old grandson. There was a language barrier. The family ran to the EMS station of where I was supposed to be stationed, but we didn't have enough people, so I was out in the county. She runs over this child, and we have a mess. So I come flying in code 3. Again, we have a language barrier. I pronounced the child dead on scene. We had brain matter from ears, nose. You had obvious marks across the chest. Covered that child up. And then what happened from there was I looked over at mom. Mom had blood, brains, and everything all over her. She's in a state of shock. She's not moving. I went and cleaned her up. As I got her cleaned up, I went back to the station. I turned it all over to PD. My supervisor was there. And then I went back on my way out to the county, and all was good. And then the next morning, I'm out in the county again because we're short. And the next day, we get a knock on the door, and it's the father. He's a Latino man. He doesn't speak but a little bit of broken English, and he wants to know where his child was taken. And that's when it hit me. And it took me several weeks of recuperating. I was fortunate I had a captain on the fire department who checked on me, and that's when I had my breakdown. And then our chaplain, I spent weeks with him. Your CISM meetings that you have, talking to someone about them. This call still gets to me, folks. It's a very heavy call. But without the support of your family, your friends, clergy, your CISM, all of those are very critical when you're working a PEDS case, regardless if it's a death or even if it's just a rough case that you have. You need to reach out and you need to look out for one another. Can we open this up for questions, Michaela?
Yep. Yeah.
I have a couple that came into me. It's Kyle here. One that came in first of all, thank you very much. I did get an hour and a half of time for you guys, so we're all good. I maybe had a feeling, but we got 1.5 hours, so you're getting your full hour and a half. The question that came in was a BLS level question for one of those fire rescue departments who does not transport patients.
Sure.
And it just disappeared on me. You talked about calling helicopter for a tachycardic ped. Would that be the same thing for one that's very bradycardic, or would it just
Absolutely.
be?
Absolutely. Okay. So yeah, if you have a child who, and I know our state well, folks. I've done a lot of traveling. Yes, I live in Sioux Falls, but I love the rural areas and things, and I know where you folks are located. And if you have that instance where you know that you're going to need a helicopter, even if the helicopter meets you at the hospital facility that you're going to, you need to get that bird up and going. We have no problem of turning around. if we're coming in a helicopter, it takes us at least 10 minutes to get lifted off. So we do a 10-minute lift off. It's basically by the time we get all the controls and everybody's situated and belted in, then we're up and then we're flying about 140 miles an hour and we're coming to you as quickly as we possibly can. And then we have that land time. And then we unload hot and we come to you. If we're coming in an aircraft, that's the same thing. We would rather turn around than not come to you at all. So don't be afraid to use your services. You've got 2 here in town. You've got Pier, you've got Pine Ridge, we've got Black Hills Life Flight, we've got North that is not too far. They're in Minnesota, so don't be afraid to use those services if you need to. And if there's resources that you need, please reach out. Sorry, I didn't put my email address on there. It's corolla.lauk@usd.edu. What else you got? Taz, come in.
Another one that came in was based on some of the flip charts and handouts or reference material that you were talking about early on. You said just get a hold of your office or those things that you guys provide to services.
Yep.
Okay.
So
Perfect.
any of these we do. So we have a number of, don't forget about our safety and injury prevention programs. We've got some really great projects that are going out there. We have resources. These are really, truly, honestly, guys, they're meant to, I know we don't want to keep things on our countertops, don't want to keep them on the countertops, but where you want to have them is that they're available. They're great for patients, you know, if you're using communication aids, they're great for patients who have even had a stroke. So you can ask those questions. I got to line up with my camera. They're great for those. They're great resources for a lot of things, but we are in the process of developing another resource that's kind of a super secret one. But once it comes out, it's going to be really cool. You guys are going to love it.
Awesome. Michaela did just put Corolla's email address in the chat box. So
very
if you
good.
want to reach out to her, that'd be great. The other question was based on some of the programs that you showed us at the end.
Mhm.
Are those all available to view and to read further on your website?
Absolutely. Yep. If you go to SDMSC, forgive us, we're going to be in the process of cleaning that up a little bit. If you go up to the top of the tab bar, it's going to be for EMS agencies. Those EMS agencies, that's where you'll find the registration to become a pediatric champion or a pediatric emergency care champion. That's where you'll find that registration to get your service up and going for your pediatric readiness award. We have a lot of resources that are kind of all contained in there. And again, it's all about, there's a lot of things that are happening in this office with 3 people, and we are so happy to share it with you. And without you folks, we can't do what we do. And we're always looking for ideas and what we can do to help you. And hang on with the PEP course. We're in the process. So the American Academy of Pediatrics, we have the PEP 4th edition that's out there. I was very blessed to be able to sit on that board, and we rewrote the whole 4th edition. We've not rolled a lot of PEP courses out due to the pandemic. The AAP is really kind of very conscientious about the pandemic exposing folks. And my biggest concern is I come out there and I'm asymptomatic, and now I go to a squad that has 5 or 6 members on it and I wipe your whole squad out. That makes me very anxious and nervous. So we're working on it. Just be patient with us and we'll get to you, I promise. So a lot of it we'll probably do online first, and then we'll come out and do skills and stuff.
Awesome.
And if you're filling out your surveys, so we had 2 winners come up. We had Wednesday winners, and our surveys were filled out. Our first winner was Standing Rock. So Standing Rock was the first one to fill theirs out, and they won a PD board, a Brazo tape, pediatric resources, and then the second one went to, who did that go to? They ended up with a PD mate. Oh, that went to South Shore. So South Shore filled out both of their surveys, and we put their name in a hat and pulled them out. And coincidentally, they did not have a pediatric restraint device, so they are the proud new owners of a PD mate. So we have a couple more drawings that are be coming up as well.
Very good. Anybody else have any questions for Corolla? And we've got some surveys coming up. Again, thank you very much, Corolla. Very, very
Absolutely.
enjoyable talk.
Thanks,
So
folks, for everything that you're doing. Be safe, be well. Look out for one another, take care of each other. I know you folks are exhausted. Those of you who are running extra calls and things, if you are open to your receiving or have the capability of receiving your vaccinations, please do so. I think Dr. Colley probably says it the best. You know what you're getting when you get the COVID vaccinations. With COVID, if you get COVID, you don't know what you get. It's kind of a Russian roulette with that. So,
very good.
all right. With that, can I sign off, Michaela?
Yes, you are good to go.
Okay, so please fill out your evaluations and kind of go from there. I hope that I didn't talk too fast. I thank you folks for your time, your consideration, and please get your equipment out and play with it. Have a great night, folks, and
Thank
a fantastic weekend.
Thanks. So the group, stay on. Don't run off too quick. We got a couple other things. Michaela, did we want to talk about that question we wanted to ask, or was that in?
That is in that eval, so I think we're good.
Okay. And then did everybody get an eval, or how do they get those?
It's right now on the poll going on that people are filling out. So
Perfect. Do we want to talk about anything else, Michaela?
Nope. I guess we'll just say one final thing, that these webinars are made possible by the South Dakota Community Foundation, who funded us in a grant that we were able to do these for you guys and continue to do them for you guys as well. So, and looking at the question, by answering the questions, you are submitting the eval as it goes. So, yep.
All right, so yeah, make sure you're filling out the evaluations and mark your calendars again. We're going to continue to do these every month. The last Thursday of the month is what we're planning. So anybody else have any questions, comments, concerns? Are they still filling them out?
Yep, they're still filling them out.
Awesome. Keep it up. Mark your calendars, February 19th through the 21st. District 4's mini conference. I need you guys to sign up for that as quick as you can. There's information on Northeast South Dakota AHEC webpage for that. Also try to make that one of your favorites, because as these webinars progress, that'll be a very, very much a focal point for you to go to, get the information, find out what the topic is on, get your Zoom link. Everything's going to be right on there.
Kyle, it looks like there's a question in the chat box that you might be able to answer.
Okay, let me see if I can find it. How long are the COVID shots supposed to last? I do not have an answer to that one. I have not heard an answer to that. From what I'm understanding is, even against some of these other strains that are out there, that it's going to be effective. Might not be the 95% effective that they are marketing it at right now, but it's still going to be effective. As far as how long it lasts, I think that's a lot of that is still in the trial stage, trying to figure out how the virus is going to mutate. So yeah, there's not been no longevity determined at this time. So it's just going to kind of depend on how things go. If you have not gotten your shot and you're an EMS provider, you need to talk with your healthcare system in your area that you work with and make sure to get your shot. EMS providers, we're in the 1C category in our state, and we're starting the 1D category. Just recent days here has kind of fired up the 1D side of things. So if you haven't got it yet, be sure to take advantage of that. All right, I don't think I have anything else. Michaela, are they still working on their stuff, or are we all good?
Yep, I think it'll still work, so I'll leave it open for a couple more minutes. But other than that, I think we're good.
All right, well, thanks a lot, everybody. Like I said, you're going to get 1.5 hours. I did make sure we had a little bit of a buffer there. And again, we thank Carola for coming on and presenting. She always does a fantastic job. So with that, I'm going to hit mute. Everybody have a good night. Thanks for being on.
Okay, and I think we are good. I'm going to close this up. So thank you everyone for attending.